we to make of the media reports of hospitalizations and deaths following immunization? Was the suspension of the AstraZeneca vaccine by no less than 18 countries last month justified? So to help us to make sense of these developments and to get a better grip on what really are adverse events following immunization, we're joined by Dr. Gagandeep Kang, Professor of Microbiology, Division of Gastrointestinal Sciences from the Christian Medical College in Vellore, Tamil Nadu. Dr. Kang is the first Indian woman to be inducted as a Fellow of the Royal Society in 2019 and also as a Fellow of the American Academy of Microbiology. She's very well known for her work in developing India's first vaccine against rotavirus and also for her contributions to vaccine development for cholera and typhoid. And her specialty is conducting extensive studies to define the burden, test vaccines, and measure their impact. So welcome, Dr. Kang. We're so pleased that you made time for us this evening. And without further ado, I sort of ask you to go ahead and discuss these issues that I flagged up in my opening remarks. Thank you so much, and over to you, Dr. Kang.
So thank you very much, Jaya, for having me here. Always a pleasure to talk about vaccines, their development, and their monitoring. So I think to frame our discussion, I thought what I'll do is take about 10-15 minutes to walk you through the process of how vaccine safety is assessed, and then open up for various questions, most of which, of course, I'm sure will be about COVID-19 vaccines. So when we think about vaccines, the first framing is that there's always a lot of news about vaccine safety. And the reason that there is news about vaccine safety in a way that there isn't news about drug safety is really because drugs are given to people who are sick to try and cure them. Vaccines are given to healthy people to prevent an infection where we don't know whether that person will actually be exposed to that infection or not. So whenever a product is given to a healthy person, doing a benefit risk assessment becomes very, very important, because we know that no drug and no vaccine is 100% safe. So I like to use the example of aspirin. Aspirin is a drug that everybody is familiar with. It is used very, very widely from babies to adults, and it's a drug that can actually result in bleeding in some people. And that bleeding, if it happens internally, can be really quite serious. But aspirin is considered a generally safe drug and is very widely used. Or if you take something like vitamins or minerals that people take as supplements all the time, actually they are not safe either. And overdose of vitamin A can be dangerous. It's a condition called hypervitaminosis A. An overdose of a mineral like zinc can be dangerous. It leads to alterations of taste and can, iron is another mineral where you can get deposition in tissues. So there is really nothing that we inject or ingest that is 100% safe. But vaccines have traditionally, and more recently, even more so, as diseases that vaccines prevent start to disappear, vaccines are being held to a higher and higher safety bar. So, for example, if we think about some of the serious adverse events following immunization that are seen with the oral polio vaccine. Oral polio vaccine can result in polio in 1 in a million children, 1 in 2 million children, because the virus can revert to neurovirulence and actually cause polio. Now, we know that now, but the same vaccine, which results in polio in children, has been responsible for eradicating polio from much of the world. So we've taken that benefit risk assessment and we've continued to use the vaccine. Now, in countries and in regions where polio has not been a problem for a long time, the Americas, for example, they don't use oral polio vaccine. They've been using an injectable polio vaccine because that vaccine does not cause polio. It also results in less protection of the gut environment, but that was considered a trade-off worth making for the increased safety that you have with an injected polio vaccine instead of an oral polio vaccine. So as diseases disappear, the safety bar becomes higher and higher. Now, the other thing to think about is when you give a vaccine and you give it by injection or you give it orally or you give it as a nasal spray, what are the things that could happen to people who are given this vaccine? And one of the things that happens if you've been given an injection is that you can have redness at the site of injection, you can have a swelling, your arm can be sore for a little while, and this is very common. This is considered a side effect. It's something that is an expected event following vaccination. Some vaccines will result in fatigue. Some vaccines will result in a slight fever. I think any mother who has taken her children for the 3 doses of vaccines that children get at 6, 10, or 14 weeks, their primary series with pentavalent or DPT vaccine, know that the first time usually goes all right, but then the second time the child is a little more irritable, and by the third time they tend to cry a bit more because these vaccines have a reactogenicity, a reaction that increases with the doses of the vaccine. The good thing is when you know that certain things are expected, then you will be able to handle them. You'll be prepared for them, you'll handle them. So many immunization clinics give baby aspirin as soon as a child has had immunization and tell the mother, well, when you go home, if your child is irritable or runs a fever, then just take an aspirin and it'll settle. We accept that. But in many parts of the world, with vaccines that are given to children, we are familiar, but we are not familiar with vaccines being given to adults. And when you have adults who are not used to taking an injection for the purpose of immunization, then they are very doubtful about taking that, very concerned about potential safety effects, and need to know even more than we would want for childhood immunization. And when that injection is for a new disease that people don't know, for a new vaccine for which you don't have a lot of data available, then the concerns really rise. Now, in addition to the common side effects that you see and can prepare for with old and new vaccines, the fever, the pain that I told you about, occasionally children can develop febrile seizures after vaccines, so fever and then a seizure that follows that. These are things that we expect and know. But in addition to that, sometimes you can have vaccines that are associated with rare side effects. I mentioned polio. 1 in a million or 1 in 2 million children who receive the vaccine developing paralytic poliomyelitis. That is called an adverse event following immunization. and that is an adverse event following immunization that is related to the vaccine. There can also be adverse events following immunization that could be related not to the vaccine, but to the vaccination process. So what's an example of that? So if you have a vaccine that requires dilution and accidentally the nurse that is giving the vaccine doesn't pick up the diluent that is meant for the vaccine, but picks up another drug and injects that instead, then you might wind up in a situation where what we will see will be the results of that drug. This is something that has happened before and has happened frequently in India. And usually what happens when you have a vaccination-related adverse event is that it'll happen in a cluster. You will have a group of children that all received immunization at the same time, all having the same effect on them, the same illness. Sometimes, we've had situations where an anesthetic was given to children and the children died when it was mistaken for a diluent. So you can have these clusters of events, or you can have vaccine-related events that will happen in that one rare child that might have been affected by the vaccine. So an example that I can give you of that is a disease that I work with, which is rotavirus gastroenteritis. We now have oral rotavirus vaccines. And when oral rotavirus vaccines are given, then there is a chance that ranges from 1 in 20,000 to 1 in 100,000 of children developing a condition called intussusception, which is a telescoping of one part of the intestine into another part. Now, this can be recognized and it can be treated quite early with an enema, but it is something that is known to happen with every rotavirus vaccine. So what I've given you is an overview. Side effects are common. Adverse events following immunization can include side effects, but also have serious events that can follow on from vaccination. Now, how do we know whether the side effect or the AEFI that we are seeing is really related to the vaccine or not related to the vaccine? This requires that you have an ability to assess cause and effect. And this is called a causality assessment. And there are specific steps that the WHO has outlined, which allow us to do that causality assessment. So if you were to have a child or an adult that had a side effect shortly after vaccination, how would you relate that back to the vaccine? Now, many of the things that we see, like seizures, like intussusception, like fever, like paralytic diseases, are things that can happen without the vaccine being given at all. These are illnesses that people have in the absence of vaccination. So then how do you know that the vaccine caused it? Well, one thing we look for is this event related in time? So let's take the example of intussusception. Intussusception usually occurs in the first week after the first dose of the rotavirus vaccine. If you have an intussusception 6 months after a child received a rotavirus vaccine, most likely, but not most likely, that child would have had the intussusception in any case. So you look for temporality, a relationship in time. The other way of looking to see whether a side effect is related to a vaccine or not is to compare the vaccinated population with an unvaccinated population. If you have an unvaccinated population, that gives you the baseline for how frequently this kind of condition is seen. And then you look to see, is the number of cases of this condition that I'm seeing actually more in the vaccinated population than in the unvaccinated population. These are the ways in which causality assessment is done. And in every country, safety monitoring of vaccines requires that there be a structure for being able to monitor adverse events that follow immunization, as well as to do causality assessment. So now coming to the SARS-CoV-2 vaccine that everybody is very, very concerned about. What do we know already? We know a fair bit because these vaccines have been evaluated in tens of thousands of people. We did vaccine trials for SARS-CoV-2. Usually when you do a phase 3 trial, you do a phase 3 trial in a few thousand people that you follow for a long time, for up to 2 years, to see whether they develop infection or not. But in this case, instead of following a small number of people for a long time, we actually did the study in a large number of people for a short duration of time. And because of that, we've been able to get safety data from tens of thousands of people. So which tells us any of the trials that have been done so far allow us to assess a risk of approximately 1 in 4,000 vaccinated individuals. So if anything is rarer than 1 in 4,000, it might not have been detected in the phase 3 clinical efficacy trials that have been done so far. What have we seen? We've seen that with the AstraZeneca vaccine, there is an increased incidence of flu-like illness, a couple of days where people feel a bit under the weather. And this is in somewhere around a quarter of the people that get the vaccine. With the Pfizer and Moderna vaccines, so with the AstraZeneca vaccine, that flu-like illness that occurs really happens after the first dose of vaccination. With the Pfizer and the Moderna vaccines, the side effects of fatigue, feeling unwell are worse with the second dose of vaccine. But in all of them, there are no serious side effects that have been noted shortly after vaccination in the conduct of the clinical trials. And everybody who has had these effects has recovered. Now, we have heard reports in the media about cases of transverse myelitis that occurred with the AstraZeneca vaccine. What's not highlighted is the fact that there was an equal number of cases in people who did not get the vaccine. So hence emphasizing that looking at baseline and comparing vaccinated and unvaccinated groups is very important. Now, once vaccines are approved for use, because right now we are in a situation where most of the vaccines we have are in restricted use or have emergency use authorization. So once they start to be used more widely in vaccination programs is where you start to pick up rare side effects, rare adverse events following immunization. And this is where causality assessment becomes even more important. So the first signal that we started to see, the vaccine started to be used in December of 2020. And the first signal that we saw was anaphylaxis with the Pfizer vaccine. And this was calculated to be at a rate of 1 in about 100,000 people who received the vaccine. What's anaphylaxis? It's a very severe allergic reaction. And it was actually then followed up and seen that it also occurred with the Moderna vaccine, but at a somewhat lower frequency, 1 in about 300,000 people. It's been attributed to polyethylene glycol, which is found in both of those two vaccines. Now, the advantage of knowing what adverse event is going to happen is, anaphylaxis generally happens within 30 minutes. And anaphylaxis can be treated very quickly with epinephrine or adrenaline. So it becomes much easier to handle. So this was the first adverse event. After that, we started to hear about sudden deaths in Norway, where 23 people in old age homes died after getting the Pfizer vaccine. Well, when it was investigated, it was found that this number of deaths was not actually unusual for Norway. It was just that this number had been noted in people who had just received the vaccine. After that, we started to hear about the AstraZeneca vaccine and the blood clots that are associated with the AstraZeneca vaccine. Well, when the news first came out, everybody thought it was just every and all blood clots. We now know that it's not about thrombosis with, it is about thrombosis with thrombocytopenia or low platelets. And it is very similar to a condition with which clinical hematologists are already familiar, which is called heparin-induced immune thrombocytopenia. So there is a treatment protocol that can be borrowed from this. Now, with this syndrome that is now being called vaccine-induced thrombosis with thrombocytopenia, or by WHO, thrombosis with thrombocytopenia syndrome, we are seeing this in Europe at a rate of 1 in 100,000 vaccinated individuals, and in the UK at about 1 in 200,000 vaccinated individuals. It's also begun to be seen with the Johnson & Johnson vaccine, which is also an adenovirus vectored vaccine. So when we start to see that two vaccines that have a similar platform have a similar side effect, then it becomes clearer that this may be what is called a class effect, that the same class of vaccines will all have a similar side effect. The advantage of knowing how common or how uncommon a side effect is to be able to do benefit risk assessments. Going back to what I started out with, for vaccines which are given to healthy people, it's very important to do a benefit risk assessment and understand that when you give something to healthy people, benefits have to significantly outweigh the risks. And that is really the situation that we are in now, where every vaccine that we have so far, we are continuing to accumulate data on safety, but wherever a benefit risk assessment has been conducted, the benefits far outweigh the risks. So we really need to make sure that this is a message that is conveyed to everybody that we deal with. Vaccines have value and they need to be used even as their use is monitored. So I'll stop there and hand back to Jaya. I'd be happy to take any specific questions that any of you have, or elaborate on some of the other myths that have come up with vaccine safety.
Thank you so much, Kang, for that, Dr. Kang, for that absolutely clear explanation defining what are side effects, what is an adverse event following immunization, and particularly the important point about the risk-benefit analysis, which is rarely spoken about in the media. We've seen some misleading headlines, such as the deaths of so many people in Norway in an aged people's home following immunization. And what are some of the ways in which you think that the media could sort of modify the way it presents these adverse events, if indeed they are linked to the vaccine?
As I mentioned, the Norwegian event was investigated, was found to not be above baseline, but it was also an important teaching moment to tell people what you need to do. When, you know, the Norwegians who were in those old age homes were very frail, elderly people. And usually when you give them a vaccine which induces a little bit of inflammation, you should take a little extra care of older people. You should make sure they're hydrated, check in on them every once in a while, not stressed out too much. And that might have helped a few of the people there. But I think in terms of how the media communicates about vaccines, I think the one thing to emphasize is that if you are picking up adverse events, it means that your safety monitoring is working. So every safety event, whether true or not, should be assessed. And we should figure out whether it is related or not. It does not make the vaccine dangerous. It makes a system that is more successful in being able to monitor the performance of a vaccine. Remember, if we know what the side effects are, we can figure out ways of being able to manage them better.
Thank you, Dr. Kang. I throw the floor open for questions.
Actually, doctor, I have a doubt. So you talked about, you spoke about the thrombotic episodes. After the vaccination, how long it will take for thrombotic episode to be happen in the, as adverse effect?
Very important question. Thank you. Because this is an immune-mediated reaction, it takes a few days for it to develop. Most of the cases that have been seen are between the time period for this is 4 to 20 days. And so far, it's mostly been seen with the first dose of the vaccine. In the case of Johnson & Johnson, it is only a single dose of the vaccine. But after the first dose, 4 to 20 days, if there are anything that indicates that you might have a blood clot. So for example, if you develop a headache and it doesn't go away, you have abdominal pain which continues to persist, you have seizures that you've never had before, you start to see under your skin multiple small blood clots, then that's an indication that you might be heading to this thrombosis with thrombocytopenia syndrome. But as I said, it is a very rare event. And if people can be told how to recognize it and to get to a facility early, give a history of vaccination, then it will be something that the hematologist will be able to handle. There is a treatment. You have to give intravenous immunoglobulin, which is available in most big hospitals. And you have to give a non-heparin anticoagulant. And those are very good at treating the condition and saving people's lives. So as media people, if you can communicate that there is a window, there are definite symptoms that make you suspect that this may be happening, and there is a treatment protocol that is available, that would be helpful.
So regarding some news articles made wrong headlines after the vaccination, or another day, next day, if vaccinated people getting die, and then they will, due to vaccination, they are they are putting headlines like that. So
Yeah.
what are the possibilities to have an immediate death after a day of vaccination? If there is possibility to have a cardiac arrest, a kind of things after vaccination within 24 hours, is it possible?
Yes. So when we look at causality assessment, we look to see, was this event, the death, caused by the vaccine, or was it coincidental? Is it just that this was going to happen in any case and it happened to a person who was vaccinated? So now what is important to be able to say whether something is coincidental or not is you need a baseline of how frequent those events are. So you mentioned cardiac arrest. So if I had 1 million people and I followed up those 1 million people for 1 month, I would have 1 million people followed up on day 1, on day 2, on day 3, on day 4, so on and so forth, right? So how many of that 1 million people would have a cardiac arrest on day 1 or day 16 or day 30, right? It's important to have that kind of baseline information and collect that before you can say that this heart attack may be, or this cardiac arrest may be related to this vaccine. Sometimes, even with baseline data, it's almost impossible to say that this event in this person was actually related to the vaccine. So, when it is a common thing that happens to people, I had a headache. Would I have had the headache anyway? Well, you can't tell me that, but if there were 30 people and they all had headaches when they'd never had headaches before, then you can say, yes, this is something that is related to the vaccine.
Gideon, you had a question, and then Bea, and then Ida. Please ask your question, Gideon.
I think she is not available with this audio. She left.
Sure. Yeah. Bea, do you want to ask your question?
Sure, I'll ask my question. I guess a lot of people are hesitant because the vaccines have not been around for that long, hence they haven't been studied that long. So we don't know what other side effects might be 2, 3, 4, 5 years down the road. How can journalists mitigate these fears with very simple language, very basic language? Thank you.
So that's an excellent question, Bea. And I think the only way to answer that is to refer them to the history of vaccines. So most vaccines, if they are going to have a side effect, will have all of their side effects within 6 months, 6 weeks to 2 months of vaccination. So, wherever we have seen side effects, there's a window where the event happens after vaccination. And we certainly, for all these vaccines, have more than 2 months of data. Now, the only place that I know of where there is an existing vaccine where it happens much later is with the dengue vaccines. And there, it's not a vaccine-related side effect. It's just a performance characteristic of the vaccine. So if the vaccine is given to somebody who has had dengue before, then the vaccine acts like a second dose and produces protection against future dengue. But if the vaccine is given to somebody who has not had dengue before, then this vaccine acts like their first exposure to dengue. And in dengue, you know that we have multiple serotypes. And if that person then gets infected with dengue, right, then that dengue infection acts like a second dengue infection, and dengue in second infections that are caused by a different serotype, you can have an antibody-dependent enhancement that occurs, where you get much more severe dengue because the antibodies that you've made have declined so much that they are actually now forming immune complexes and causing damage. So that's the only situation that I know of where you've seen a side effect 2-3 years down the line after you've had vaccination. This is similar to something that there was a vaccine that was developed in the 50s and 60s for respiratory syncytial virus. And this vaccine, when children were given the vaccine and then subsequently they encountered the virus, they actually developed an enhanced respiratory disease, and some of the vaccinated children died. We didn't understand why that was happening for decades. We now understand that it is because there are many kinds of antibodies that are made in response to an RSV infection or to RSV vaccination. And we have to induce a kind of vaccine, a kind of antibody that is made to a shape of the dengue virus protein before the virus gets inside human cells. So what had been done is that the vaccine had been made using the shape of the virus after it had got inside cells. And actually what we needed was antibody to the shape from before. So we know that now, and new dengue vaccines are, new RSV vaccines are in development that that have the shape before the virus gets in, and those vaccines are not showing any signs of danger. So, understanding what happens is also one way of making safer vaccines.
Thank you.
Ida, you had a question, and then Sunny, and then Gideon.
Thanks, Jaya. Thank you, Dr. Kang. You explained it so clearly. Can you help us with ways to, as journalists, to talk about age as a factor? In the beginning of COVID-19, we always heard that being above a certain age group, meant that there were more negative effects of the virus itself. And now when it comes to vaccine reporting, we hear that sometimes being below a certain age group carries risk. Could you explain to us what it is about the immune system that makes this a factor, and help us put it in simple language again for our audiences?
So Ida, it isn't about the immune system. It's about the benefit risk assessment. So I think what you're referring to is what has been recommended in the UK, which is that people below the age of 30 should get the Pfizer vaccine instead of the AstraZeneca vaccine. And that is based on the fact that if you have a 1 in 250,000 person risk of the AstraZeneca vaccine causing clots, right? Thrombosis with thrombocytopenia, that is clearly a risk. But if you look at what is the risk of COVID-19 disease in those individuals, then that risk is lower in younger people, of a severe outcome and death is much lower in younger people. So the analysis that was done was to look at age stratification, but also look at in a situation where you have lots of virus around, where you have a moderate amount of virus around, and when you have very little virus around. So this benefit risk being slightly in favor of not using the vaccine in the under 30s only applies when there is a low transmission of the virus. As soon as the risk of disease, the risk of infection and the risk of disease goes up, there is more virus circulating. Even in the under 30s, the risk-benefit assessment is in favor of using the AstraZeneca vaccine in that age group too.